This is Dr. Pankajam, a radiologist passionate about lifelong learning. I believe teaching is the most effective way to keep learning. And today we are tackling one of the most important yet most confusing presentations in medicine, that is jaundice. This video is not just for radiologists. Whether you are a clinician, a medical student, a junior doctor, or a sonologist, jaundice is something you will encounter. And the way to approach it is the same for everyone, a systematic integrated approach. Let's start with the golden principle that will give everything we discussed today. History plus examination, laboratory findings plus imaging equals diagnosis. No single tool works alone, not even imaging, especially not imaging alone. As a radiologist, my job is to answer three questions. Is this pre-hepatic, meaning the problem is before the liver, usually excess bilirubin production from haemolysis? Is this hepatic, meaning the problem is within the liver itself, it is hepatocyte damage? Or is this post-hepatic, meaning there is an obstruction to bile flow after the liver? The single classification, pre-hepatic, hepatic, and post-hepatic, determines everything that follows. Determines whether the patient needs medical management, endoscopic intervention, or surgery. Pre-hepatic jaundice, excess bilirubin production, usually from hemolysis. Unconjugated bilirubin rises. Liver and bile ducts are completely normal on imaging. Hepatic jaundice, the liver cells themselves are damaged. Conjugation is impaired. You get a mixed pattern of bilirubin, both conjugated and unconjugated rise. Post-hepatic jaundice, bile cannot flow out. There is obstruction. Conjugated bilirubin predominates, and on imaging, the ducts are dilated. Now, here's the thing. Imaging alone often cannot tell you why. It tells you where the problem is. The why comes from putting everything together. And that's what we are going to do today. Walk through how history, examination, and laboratory findings guide us before and alongside imaging to reach the diagnosis. Before any scan, before any blood test, the patient's history often points us directly towards the answer. 5 quick key questions to ask every single jaundice patient. Question number 1. Stool color. Normal or dark stool means bile is reaching the intestine. This could be pre-hepatic or hepatic jaundice. But clay-colored, pale or acholic stool means bile is not reaching the intestine. That's post-hepatic obstruction. Acholic stool means obstruction until proven otherwise. Question number 2. Urine color. Dark urine with normal colored stool means conjugated bilirubin is being excreted in urine. This points to hepatic or post-hepatic causes.
Post-hepatic, conjugation is normal, obstruction is present. Predominantly conjugated bilirubin is filtered into the urine, so you get a dark color. Pre-hepatic, that is hemolysis, unconjugated only, not filtered. Urine bilirubin is negative, acholuric jaundice.
Question number 3. Itching or pruritus. If itching comes before jaundice, bile salts are accumulating. That is cholestasis. Think primary biliary cholangitis, especially in a middle-aged woman, or any obstructive cause. If itching is absent or comes after, cholestatic causes are less likely. Question 4. Abdominal pain. Right upper quadrant colicky pain with jaundice. Think stone. Add fever to that pain and jaundice, that is Charcot's triad. Right upper quadrant pain, fever, and jaundice, meaning ascending cholangitis. This is an emergency. But painless jaundice with weight loss in an elderly patient, this is classic presentation of pancreatic or periampullary malignancy. Painless jaundice in the elderly should always raise the alarm for malignancy. Question number 5. Timeline and context. Sudden onset with fever and malaise suggests acute hepatitis, viral or drug-induced. Gradual onset over months with weight loss and anorexia suggests chronic liver disease or malignancy. Recent travel or contaminated food, think of hepatitis A or E. Recent drug history, think drug-induced injury. Recent blood transfusion, think hemolytic transfusion reaction. A few more clinical clues. Family history of jaundice points towards genetic causes like Gilbert syndrome, Wilson's disease, hereditary spherocytosis. Alcohol history points towards alcoholic fatty liver disease or cirrhosis. Neuropsychiatric symptom in a young patient, always think Wilson's disease. Fever with weight loss in India, always keep tuberculosis on your differential. And in pregnancy, think HELP, HELLP syndrome, acute fatty liver of pregnancy, or intrahepatic cholestasis of pregnancy. Notice that we haven't even picked up the ultrasound probe yet, and already the history has narrowed our differential significantly. This is the foundation everything else builds upon. Physical examination bridges the gap between history and investigations. 5 key findings to assess in every jaundice patient. Finding 1. The spleen. Massive splenomegaly in jaundice points towards pre-hepatic causes. Haemolysis. Think thalassemia, sickle cell disease, malaria, or hereditary spherocytosis. On the other hand, mild splenomegaly accompanied by signs of chronic liver disease points towards hepatic causes, specifically portal hypertension from cirrhosis. Finding 2. The liver itself. A smooth, tender, enlarged liver suggests an acute hepatic process, acute hepatitis, or venous congestion. A hard, nodular, often shrunken liver suggests cirrhosis. But here's a critical combination: hepatomegaly together with palpable gallbladder. That's Courvoisier, and it changes everything. Courvoisier, a palpable non-tender gallbladder in a jaundice patient means malignant obstruction until proven otherwise. Pancreatic head carcinoma, ampullary carcinoma, or cholangiocarcinoma. Remember, Courvoisier, a painless palpable gallbladder with jaundice is unlikely to be gallstones. Why? Because gallstones cause chronic inflammation and fibrosis of the gallbladder wall. It becomes scarred and cannot distend. Only a gradually progressive malignant obstruction in a previously normal gallbladder allows it to distend enough to become palpable. Finding 4. The stigmata of chronic liver disease. Spider angiomas, palmar erythema, gynecomastia, caput medusae, those dilated veins radiating from the umbilicus. Ascites, asterexis, that flapping tremor, and testicular atrophy. All of these together point towards hepatic cause, especially advanced cirrhosis. Finding 5. Special signs that are diagnostic. Gold Kayser-Fleischer's rings on slit lamp examination, that is Wilson's disease. Skin pigmentation with hepatomegaly, that's bronze diabetes. Hematochromatosis. Xanthelasma, those yellowish cholesterol deposits around the eyes, combined with excoriations from scratching. Chronic cholestasis, think PBC, and lymphadenopathy. Consider tuberculosis, lymphoma, and metastatic disease. By the time you finish history and examination, you often already have a strong working diagnosis. And even before the first blood test, or ultrasound. That is the power of integration. Laboratory tests bridge clinical suspicion and imaging. And the very first test in any jaundice workup, bilirubin, unconjugated versus conjugated. If unconjugated bilirubin predominates more than 80%, indirect, think pre-hepatic causes, haemolysis, Gilbert syndrome. If conjugated bilirubin predominates more than 50%, think hepatic or post-hepatic causes. This single test immediately narrows your diagnosis. Next, liver enzyme patterns. Two distinct patterns. The hepatocellular pattern, AST and ALT are markedly raised, while alkaline phosphatase is only mildly raised. This points towards hepatic causes, hepatitis, cirrhosis. The cholestatic pattern, alkaline phosphatase and GGT are markedly raised, while AST and ALT are only mildly raised. This points towards post-hepatic obstruction or cholestatic hepatic conditions like PBC or drug-induced cholestasis. This AST to ALT ratio gives more clues. A ratio less than 1 suggests viral hepatitis or fatty liver disease. A ratio greater than 2 is the classic pearl for alcoholic liver disease. And if AST and ALT are in the thousands with a ratio greater than 1, think acute severe injury, drug toxicity, ischemic hepatitis, or acute viral hepatitis. Other essential tests, prothrombin time reflects the liver enzyme synthetic function. A prolonged prothrombin time in the setting of jaundice indicates severe hepatocellular damage and is a poor prognostic sign. Albumin, low albumin suggests chronic liver disease, and the complete blood count, anemia with reticulocytosis, points towards hemolysis, while pancytopenia suggests hypersplenism from portal hypertension. If bilirubin fractionation shows unconjugated predominance, you proceed to the hemolysis workup. Reticulocyte count elevated in hemolysis. LDH elevated. Haptoglobin low because it's being consumed binding free hemoglobin. Direct Coombs test indicates immune-mediated hemolysis from ABO or Rh incompatibility or drug-induced hemolysis. And the peripheral smear, look for spherocytosis, sickle cells or schistocytes. Finally, serology markers for specific diagnosis. Viral hepatitis, IgM anti-HAV for acute hepatitis A, HBsAg for hepatitis B, anti-HCV for hepatitis C, IgM anti-HEV for hepatitis E, autoimmune hepatitis, anti-SMA, ANA, anti-LKM1 and elevated IgG, PBC, anti-mitochondrial antibody, AMA 95% sensitive, Wilson's disease, low ceruloplasmin and elevated urinary copper, hemochromatosis, elevated ferritin and transferrin saturation. By this point, history, examination and labs, you've already arrived at a working diagnosis. Imaging now plays a confirmatory and localizing role, not a primary diagnostic one in most hepatic causes. But for post-hepatic causes, imaging becomes absolutely central because only imaging can show where the obstruction is and what is causing it.
Part B coming soon. Subscribe and follow Punky's Medical Corner.